Hello, everyone, and welcome to the Q&A session on Hodgkin lymphoma. My name is Rashida, and I'm the Digital Marketing Manager at Lymphoma Canada. I will be the facilitator for this session today. I'm pleased to welcome here Dr. Robert Pakren, who will answer your questions from the breakout sessions on Hodgkin lymphoma, also known as HL. As a reminder to our audience members, please type your questions in the Q&A chat box in the middle of the black toolbar at the bottom of your screen. We will try to answer as many questions as possible. So I can see a first question here, Dr. Robert. So the first question is there any updates on the risk of scuba diving with the use of the bleomycin, and does it apply to brentuximab as well?
That's an interesting question. We don't use a lot of bleomycin nowadays in Hodgkin lymphoma, thankfully. That particular drug can cause injury to the lung, especially for people who have underlying lung disease, like if they have an extensive smoking history or if they're older, for example. So in that situation, we tend to be quite cautious and monitor the lung function closely. With scuba diving in particular, I guess with the high amounts of oxygen involved, there's a theoretical risk of exacerbating bleomycin lung injury. Truthfully, it's not a question that comes up a whole lot, so I don't think there are any recent updates on this particular combination. It's probably best to check with your treating doctor to be safe. But in general, we've moved away from using a lot of bleomycin in Hodgkin lymphoma. For many patients, we can now limit it to just 2 cycles. So the risk of getting lung injury after that is quite low with less bleomycin, and people can get back to their activities like scuba diving more quickly. There are a lot of new treatments for Hodgkin lymphoma as well, where we're getting rid of bleomycin and replacing it with more effective treatments that are also better tolerated, like brentuximab or nivolumab, for example. So many patients nowadays, especially with advanced stage Hodgkin lymphoma, receive one of these new regimens. And without the bleomycin, there isn't the same risk to the lungs. Brentuximab can be hard on the nerves and cause neuropathy, numbness, tingling in the fingers or toes, but not directly hard on the lungs and shouldn't affect your ability to scuba dive.
Awesome. Thank you, Dr. Roberts, and thank you, Kari, for your question. So let's take another question. Are there certain genetic factors, family history, or other predispositions that increase chances of developing Hodgkin lymphoma?
So for most patients, we can't really pinpoint an exact cause that led to the lymphoma. I tell my patients that there's nothing that they did that could have caused this or that they could have done to have avoided it. It's usually bad luck, and it's just these random mutations that can occur in our lymph nodes that turn a normal, healthy lymph node into an enlarged cancerous one. That's usually how these lymphomas develop. There are a number of different risk factors that can increase the risk of Hodgkin lymphoma. The main one's probably age. So it most commonly affects people in their 20s or 30s. Sometimes it can occur in your 60s as well. That's the most important risk factor. But there are some other potential risk factors too. Ethnicity, family history, certain viral infections, for example, they might increase the risk a little bit. But in general, Hodgkin lymphoma, it's not like directly transmitted from generation to generation. It's just there might be a slightly higher risk in other family members, but most people in the family still don't get this lymphoma.
Awesome, thank you. So to the audience, keep typing your question into the Q&A chat box, into the chat. And let's take another question. So there's someone who said, I've heard of people feeling pain or tingling after drinking alcohol before being diagnosed with HL. Is there a real connection between alcohol and Hodgkin lymphoma?
So alcohol probably doesn't directly cause Hodgkin lymphoma, but interestingly, alcohol can sometimes cause the lymph nodes to become tender if a person has Hodgkin lymphoma. So there are some patients, it's not that common, but they may not even notice an enlarged lymph node. They have not yet been diagnosed, and they drink some wine, and suddenly their lymph node is all tender and sore, and that's what actually brings the disease to their attention. It's not entirely clear why this happens. It's something unique to Hodgkin lymphoma. There may be some sort of metabolite in the alcohol that maybe causes some inflammation in the lymph nodes. It's not entirely clear, but tender lymph nodes after alcohol can be a symptom of Hodgkin lymphoma. It's just not directly a cause.
Perfect, thank you. I see another question here. So I'm on treatment, Nivo AVD. My TEP scan after 4 chemios shows complete metabolic response, but I still have night sweats. Could it be related to neuropathies? My inflammatory blood factor are also normals.
So night sweats are a tricky symptom. They can be a sign of Hodgkin lymphoma. Sometimes the lymphoma is very inflammatory when it gets first diagnosed, and it can cause a lot of inflammation in the body that can lead to fevers and fatigue and unexplained weight loss and night sweats as well. The night sweats of Hodgkin lymphoma, they typically are very severe and actually drenching, like people can wake up with the shirt and the sheets soaked with sweat. So that can occur in Hodgkin lymphoma. Usually the symptoms do get better once treatment is started, the lymph nodes shrink away, and it sounds like the patient's PET scan here looks very good with no signs of active disease, which is a very reassuring sign that chemotherapy is working. The night sweats are also a non-specific symptom because many other things can cause them, especially if they're milder or not so drenching. Sometimes weather changes at this time of year, hormone changes, infections, and other factors like menopause can cause night sweats too. So I would just check with your family doctor or your oncologist to review those symptoms. Are they getting better? Are they getting worse? How bad are they? And what else might be causing them? But they could potentially be related to other things than the lymphoma itself.
Thank you. Um, so we can go to the next question. So is there any use of CAR-T therapy with HL? I see there are some trials for RRHL.
So we currently have CAR-T approved in Canada for a number of lymphomas, mostly B-cell lymphomas, but not yet for Hodgkin lymphoma. It has not yet been approved elsewhere in the world for this particular disease as well. But there are a number of clinical trials going on looking at CAR-T in this disease. They target a different tumor antigen than our typical or tumor surface protein compared to our typical lymphomas. But there have been some early trials showing that patients with Hodgkin lymphoma can respond to CAR T cell therapy. The disease is different from other B-cell lymphomas, so it's not yet clear if CAR T is as effective for Hodgkin as it is for other diseases because the sort of immune cells around the lymphoma are very different. But there have been some promising early results. It's just that the studies are still kind of early, and we need larger studies, and we need also more monitoring to know how well CAR T works over the long term. So I don't think there are any trials open in Canada right now with CAR T for Hodgkin lymphoma, but I think there still are some in the US. So we'll see over the next couple of years if we get some more promising results, and hopefully one day soon we will have CAR T for Hodgkin lymphoma as well.
Awesome. So next question, does having B symptoms like I did with weight loss and night sweats mean that my HL is harder to treat?
Well, I think nowadays our treatments are so effective for Hodgkin lymphoma that most patients still do respond very well, and the majority do end up being cured. If there are night sweats or fevers or unexplained weight loss present at diagnosis, it sometimes just changes our treatment because it can mean the cancer to be a little bit more advanced and it will require more treatment, for example. So if there are night sweats, fevers, or other risk factors, like a lot of lymph nodes that are affected or different organs affected, it might require either a stronger chemotherapy or more rounds of chemotherapy to get rid of the disease effectively. But at the end of the day, the majority of patients still do very well. They just might require extra treatment to get there.
Great. So yeah, to the audience, please keep asking your question. We're getting them in the chat. And yeah, here a new one. Are there lifestyle changes or preventive measures that can help reduce late effects from treatment?
It depends a little bit on what treatment you received. In general, we try to minimize the amount of treatment that can cause late side effects because many folks with Hodgkin lymphoma are young. We have to think about their health 10, 20, 30, 40, 50 years down the road. So you can chat with your doctor to see what might be recommended in your situation. The main thing is just to take care of your long-term health. So exercise each day, eat a healthy, well-balanced diet, try to avoid smoking or excess alcohol intake to reduce the risk of other cancers, take care of your mental health and get good sleep each night. Those are the main things just to maximize your long-term health. It's good to see your family doctor once or twice a year to do your baseline screening for things like diabetes and cholesterol levels. There can be a higher risk of heart problems after some chemotherapies, for example. If you've had radiation as part of your treatment, that can also cause some later side effects like second cancers or thyroid problems if that was affected by the radiation. So maybe some cancer screening to do with your family doctor to screen for late complications and some blood test monitoring to look for some of those as well.
Yeah, sure. Thank you. Next question, what long-term risks should survivors be aware of, such as secondary cancers or organ toxicity?
So it depends a little bit on each person, what their underlying health problems might be, and what treatment they received as well. In general, with any chemotherapy treatment, there is a small risk of second cancers like leukemia, for example, that can occur from damage to the bone marrow. Thankfully, that risk is quite small with most Hodgkin lymphoma treatments. It's usually just a small percentage risk. So it's very rare to see it. But it is a good idea just to see your family doctor for an annual checkup and like do your blood count monitoring, for example, just to make sure your blood counts are looking good and the bone marrow is still healthy. Other than that, the risk of other cancers can be increased if you had radiation, like I mentioned. So if there was radiation to the chest area, there could be a need to do breast cancer screening in the future to monitor for that. And then, yeah, some of the other late complications that we touched on earlier, just trying to have a healthy lifestyle, avoid excessive alcohol and smoking and things like that.
Thank you. So I'm checking the chat for upcoming questions. Yeah, here is one. The question says, I'm concerned about neuropathy from brentuximab vedotin. How do you monitor for it, and what steps are taken to manage or reduce nerve damage during treatment?
So brentuximab is a very effective new treatment for Hodgkin lymphoma. It's like an antibody with a little bit of chemo attached to it, and it delivers the chemo directly to the lymphoma. It's been shown to be very effective for the disease when it's relapsed or as part of the first treatment in combination with other chemotherapy drugs. But its main downside is that it can be hard on the nerves and cause numbness and tingling in the fingers or toes because of nerve damage. So we usually check in with patients before each round of brentuximab is due, and we check the nerve function. Are you having any symptoms like numbness, tingling, trouble using your phone, trouble writing, things like that? You can report it to your doctor. If these symptoms are mild and stable, we can often continue brentuximab with close monitoring. But if the symptoms are getting more severe or they're affecting your functioning, like you can't button up your shirt, for example, or you can't use your phone, then we'll often reduce the dose of the brentuximab. Or if it's being given with another chemotherapy drug, vinblastine, we can also reduce the dose of that one because that one can be hard on the nerves. Or if things are really significant, we sometimes hold the drug for a little while to let the nerves settle. Or sometimes if it's very severe and our other treatments have not worked, we have to stop the treatment early. So those are all different options that can help people get through brentuximab safely. Usually, once treatment is done, the nerves do have a chance to recover. It can take a while, sometimes months or even a year or two, but the nerves do usually slowly regenerate. And in most people, the neuropathy does improve over time. Doesn't always fully resolve, but at least in most people, it does become more manageable as time goes on and the body heals and recovers from the treatment.
Thanks. So another question showing concerns about night sweat. So the question is, what would you describe as moderate night sweats?
So the true night sweats of Hodgkin lymphoma are typically drenching, which means that the shirt, the sheets, the bed are wet with sweat. So those are the ones that are more suggestive of Hodgkin lymphoma, but again, night sweats are kind of non-specific and many other things can cause night sweats. So if they're moderate, like they're not drenching the shirt or the sheets and they're not occurring every night or getting worse over time, that may in fact be from something else. So you can check with your physician and see what they think and keep an eye on those symptoms. It can be useful to sort of keep a journal to record how many nights per week these sweats are happening and how severe they are. And then you can get a sense of how they're evolving over time.
Thanks. Another question from someone in the audience. So what Dovell score at the mid-bit would warrant the client to change from ABVD to salvage chemo with stem cell transplant?
So Deauville score refers to how bright the lymphoma is on the PET scan. If the Deauville score is 1, 2, or 3, then the lymphoma is no longer lighting up on the PET scan, and we call that a complete response, where we don't see any signs of the lymphoma remaining. So ideally, the Deauville score will be 1, 2, or 3. However, in a minority of patients, the Deauville score may be higher. It may be 4 or 5, which means that there still could be some lymphoma that's remaining active. It all depends on the situation. If the lymphoma is improving, like most of it is gone, the lymph nodes are shrinking, but there's still some areas that are bright with a Deauville score of 4 or 5, then we might consider switching from ABVD to a stronger chemotherapy called Biacop. That's a German chemotherapy protocol that's been shown to be more effective than ABVD, especially when the PET scan partway through treatment is still lighting up. But it's not necessarily done at all hospitals. It's a unique treatment. If the PET scan shows that things are actually getting worse, like there's new lymph nodes growing on treatment, or the old lymph nodes are increasing in size, now that's a rare situation, but that's actually a more concerning one where the disease is actually fully resistant to the ABVD chemotherapy. So in that situation, it's Deauville 5 and it's getting bigger, we might consider switching to an entirely new treatment, like a stem cell transplant, for example, to get rid of the disease.
Thanks. So another question from a patient. She's saying, in July, I just finished treatment for nodular lymphocyte, predominant Hodgkin lymphoma, 6 cycles of TROP-R with Grestofil. August, the PET CT scan showed complete remission. I turned 72 in April. I did not have the usual B symptoms, was discovered via a mammogram. Note, I'm feeling better all the time and my hair is growing back. Still have chemo brain, doing exercises, etc. My question, the name is changing. Does that mean it will leave the Hodgkin lymphoma on the basis of its clinical pathologic spectrum? I have found support elsewhere via Facebook. Is there specialty support groups or interest groups in Canada for this cancer?
Yeah, good question. So this is sort of a rare subtype of Hodgkin lymphoma. Most of the Hodgkin lymphoma we see is called classic Hodgkin lymphoma, and that's what we've been discussing so far. But nodular lymphocyte predominant Hodgkin lymphoma, or NLPHL for short, is a less common type of Hodgkin lymphoma that in the past was considered part of the family of Hodgkin lymphoma because of how it looked under the microscope. But now with more advances in our understanding of the biology of the cancer, we're shifting and we kind of now realize that this is probably actually no longer a type of Hodgkin lymphoma, despite the name. And some guidelines, it's now been sort of rebaptized as nodular lymphocyte predominant B-cell lymphoma. So this disease, it behaves very differently from regular Hodgkin lymphoma, and it's also treated very differently. It's actually much more similar to an indolent B-cell lymphoma, like follicular lymphoma, for example. It tends to present with small lymph nodes. It usually has a very good prognosis over the long term. It can respond to rituximab, like this patient received, which we don't use for Hodgkin lymphoma. And many patients can be monitored for many years without treatment if it's very small and not causing any symptoms, which is different from Hodgkin lymphoma. So right now, some groups are still using the term Hodgkin lymphoma for this disease, but there's an increasing shift towards giving it a new name, and it's probably better thought of as an indolent B-cell lymphoma, more like follicular lymphoma, for example. But it is a unique entity. It's rare. I'm not sure if there are any specific support groups in Canada, but I do know there's something called the GLOW Consortium, GLOW, and it's sort of this international group dedicated to this particular rare lymphoma. And their website does mention some patient resources. So I'd take a look at that and see what might be available.
Awesome, thank you. Another question says that Dr. Costello in her presentation said that typically there is peak of developing Hodgkin lymphoma between 15, 35, and 55 years old. I'm currently 34 years old under treatment. Is there more chance I get a relapse at 55?
Not exactly. Usually what we're referring to here is the age at which the cancer first presents or first gets diagnosed. So there's one peak where the cancer can first get diagnosed in folks who are in their like sort of 15 to 35 age group. That's the most common. But there's another peak for people who are in their 50s and 60s where lymphoma can get diagnosed at that time period as well. But most of them didn't have lymphoma when they were younger. They're getting it for the first time at that age group. For folks who are young and get Hodgkin lymphoma, the majority of the time they do go on to be cured. There is a small chance the cancer can come back. If it comes back, it usually comes back within the first couple of years, the first 2 to 5 years especially. So it's very rare to see lymphoma come back 10, 20, or 30 years later. In that case, it may actually be an entirely new lymphoma happening a second time in an unlucky patient. But it's uncommon for that to occur. So, for this person, I wouldn't be too alarmed at the risk of relapse at the age of 55. Like I said, the majority of people don't have a relapse, and if it was going to happen, it usually happens in the first few years, and it usually still is treatable if the cancer even does come back.
Thank you, Dr. Robert. And the patient that asked about the support group, she added, and I had night sweats more, but not drenching. Thought it was my age, but the night sweats have stopped completely now after treatment. So maybe saying drenching night sweats misleads people.
Yeah, it's very tricky. Like night sweats can be caused by so many things, including lymphoma, but many other factors can cause it too. Hormone changes, infections, weather changes, sometimes even reactions to certain chemotherapy medicines like steroids or GCSF injections, for example. So it's hard to know exactly what was causing the symptoms in each individual case. The classic ones with Hodgkin lymphoma do tend to be drenching, but you're right, every person, every disease is different. So some people might present with milder symptoms, but many people worry that if they develop a night sweat, the lymphoma may be back, but oftentimes that's actually not the case, and it does end up being something else causing the night sweats. So I would just try not to assume it's directly due to lymphoma. Chat with your doctor. It could be something else causing it as well. But each case is different. I agree.
Yeah. And she added, should I be looking at B cell group then?
Well, I think I'm actually stepping in for Dr. Costello, who gave the talk earlier and couldn't attend the Q&A session. I'm not sure, did she have a chance to cover an LPHL during her talk earlier? We'd have to review. But it probably deserves its own session, I would say. It's a rare lymphoma, and despite the name, it really isn't treated like Hodgkin lymphoma. It has its very own unique treatment. So if there wasn't a session dedicated to it this year, I think next year with Lymphoma Canada, we should work on getting a session for NLPHL because it is a very unique disease.
Yeah, and for sure, please do not hesitate to channel your questions later by email to us, and we can get Dr. Costello look at that. So last question we're taking today, as we have to wrap up the session soon. So does CHL have higher rates of relapse than average, or is the risk quite minimal?
So Hodgkin lymphoma is probably one of the most curable cancers. It depends on each person. It depends on the age as well. The chance of relapse is higher for people who are older because it's harder to treat that particular lymphoma in that age group. But for young people, the majority do go on to be cured. It depends on the stage and other risk factors, but probably more than 80% of patients go on to have a very long-lasting remission and are cured of the disease. So the relapses can occur, but it's in a minority. And thankfully, relapses are occurring even less often nowadays than in the past because we have new effective treatments. So with some of the newer treatments like Bricad or nivolumab AVD, for example, the cure rates are greater than 90%. So the relapse risk is quite small and getting smaller.
Okay. So thank you everyone for your questions. And I would like to thank Dr. Robert for taking time to participate in today's Q&A session and jump in for Dr. Costello. So we hope those watching today learned something new about their loved one's lymphoma subtype. Please tune into the next session titled Accessing Clinical Trials in Canada, which will be starting shortly. Thank you, everyone.
Thanks so much. Have a great day, everyone.
Thank you. Bye-bye.